And welcome to our Lunchtime Ready Format Development and Refresh. Nice to see some people joining us. As I say, we don't tend to know who's coming, so it's lovely when people do show up. For those of you that are on the meeting, there will be a recording available afterwards that we will share, and then we'll share it with other professionals for them to share on their social media and things as well. We would encourage anybody that is on your teams to have a watch back. It's really useful, and it's the first time we've offered such a training like this, so it'd be really good to get it out there and for as much exposure as possible. Just a bit of housekeeping from me. So as I've said in the chat, if we can just keep all the questions, we won't do hands up and things. If we could just keep the questions to the chat, that would be great, just so we can power through. We've got a lot going on in the session, so there may well be questions, but we can share that at the end, just to make sure that we're not going off track. So my name is Lindsay Wilson. I am the Healthcare Development Manager for CPLSC. I'll be chairing the meeting and jotting down all your questions going through. We've got Vicky Shackleton here with us from CGL. Give us a wave, Vicky. We've got Dami as well with us. Give us a wave, Dami. And we've got Faye Humphreys as well with us. Give us a wave. And we've got Katie Egan, who, if those of you who aren't familiar with Katie, she is the integration lead for CGL. So she's here. She's not presenting, but she's just going to be listening in and probably answering some of your questions. Next slide, Deb. So we've got welcome, introductions and housekeeping, which I've kind of covered. Then we've got a quick session on ketamine risks. So we'll go through all the things with the experts for that. We've got a Buvidal overview, and then Dami's going to do us a little bit of a walk through on some farm outcomes, you know, typical errors and things like that that people are coming across. We'll have question and answer at the end, as I've mentioned, and then we'll close. If we don't get round to anybody's questions, please do still put them in the chat, and we'll come together as professionals afterwards and try and get everything answered for you. We don't want you to come away with any questions unanswered or anything like that. Okay, so let's get started. I will mute myself.
Great, thank you very much. My name's Vicky. I work for Inspire Drug and Alcohol Service, and I'm the community educator. So I work across the whole of Lancashire, and I deliver awareness sessions around drugs, alcohol, naloxone, ketamine. We also do an hour Audit C training session, but I will pop some links in the chat for that at the end when I've finished and we've moved on to the next person. So I've just been asked to put together a little bit of information around ketamine risks. I've only got 10 minutes, so I've just taken some of the things that I go through during our 1 hour ketamine awareness session that I deliver online or face-to-face for other professional agencies. And if you've got any questions, please ask. There's loads of people on here as well that will also be able to answer your questions, fingers crossed, if I don't know the answer. So what is ketamine? So it is used in human medicine and veterinary application, has been for decades. It has lots of different names that you might hear out there amongst the community, in particular younger people as well, which we are seeing presenting at our services more frequently. And things you might hear are KET, HitCat, Bump, Cat Killer, Special K, and everywhere I go to deliver awareness sessions around ketamine, each organisation give me a new name of what it goes by. It is a just dissociative anaesthetic, so that means that people will experience dissociation when they use it. So people report kind of an out-of-body experience where their mind and body have dissociated, for example. It's also an analgesic. It's a pain relief medication, so if people experience extreme trauma, for example, in hospital settings, they'll be given that to help with pain relief, and it will have the effects, people will often not remember what's happened whilst under the influence of this substance. It has got hallucinogenic effects as well. It doesn't come under that category on the drugs wheel. It comes under the dissociative, but it does have hallucinogenic effects, which is one of the reasons people do like using it. And as you'll have seen, it is used in treatment programs for depression in controlled studies in the UK. Following its use, it is rapidly distributed in the central nervous system, and its effects can last for up to 2 hours. Everybody will experience this differently when they use it, you know, and everybody will react in a different way. It can be used in various different ways. So we often see the most common one that we see in services, people snorting it, although some services, and I work with a lady from With You on delivering training for other organisations, and she said that they know of one person recently that has been injecting ketamine rather than snorting, and that is a result of her damaging the septum in her nose, so can no longer snort it. And then other methods, similar with other powder substances, like bombing, which is where somebody will wrap it in a dissolvable paper and swallow it, or swallowing it as a medication, you know, tablet form. But I would say that the most common method that we see in services is snorting it as a powder. It is currently a Class B drug, and it is relatively cheap to buy in comparison to cocaine, for example. So I think that's one of the reasons why we have seen a change in the, you know, the people that are using this. So amongst the younger crowd, something, you know, that's so easy to get hold of, so cheap, it tends to end up being the drug of choice. So that's one of the things that we are seeing. And because it's a Class B substance, the current timeframes for kind of if somebody is caught in possession of this is up to 5 years in prison. They might receive a fine, or they might receive both. We very rarely see these sentences coming through the criminal justice system. And if somebody is found guilty of supplying it, they could receive up to 14 years in prison, a fine, or both. So one thing that they really work on at With You service, young people service, when they are seeing people come through, is that people don't seem to be, they don't realise that if they're buying a substance in a certain amount and sharing it amongst friends, that they are guilty of a supply offence. So that's something that we will work on with our young people's worker in Inspire, and also the young people's service as well. So I've just popped up here the impacts of the physical and on physical and mental health. I've just popped everything up there for everybody to have a little look at. The top 3 under physical health, so ulcerative cystitis, urinary tract damage and incontinence, all things that would come under the diagnosis of ketamine bladder syndrome, which we will touch on the next slide. You know, repeat UTIs, these are all things that people might be presenting with if they've got bladder damage. Also abdominal and back pain as a result of the damage that's being caused, memory loss sometimes, and as a result we'll see trips, falls, injuries, people presenting with black eyes and things like that because of that dissociative effect. People are not kind of in control of the bodies, you know, and accident prone, and you might see people presenting. There is that risk of bloodborne viruses. Oop. Thank you. Risk of contracting a bloodborne virus, as with other substances, for, you know, if people are injecting or sharing equipment, the same as injecting any other substance or sharing keys, notes, anything like that to take that drug in powder form. Depression of the central nervous system, a weakened heart function, and then ultimately, you know, death from kind of organ failure once people's bodies start to shut down, and, you know, as a result of that damage. Any mental health impacts that we might see include hallucinations, which might not always be a positive experience if somebody starts taking this substance for that. You know, if somebody's not in a good place, then it's normally reported that somebody's hallucinations, or, you know, if somebody's having a trip, for example, it will be a negative experience. You've got that disassociation and detachment, sometimes psychosis, flashbacks, confusion, disorientation, anxiety and depression, and not necessarily just whilst using the substance, but as a result of physical damage to the body, you know, and that long-term effect that can have on somebody that might ultimately have had to have had the bladder removed and replaced with a bag permanently. irritability, and memory loss. We'll just skip on to the next slide. So there's 3 different stages of ketamine bladder syndrome. So stage 1 is the inflammatory phase. There's lots of big words in here that I will try my best to pronounce. Characterised by normal ureters, renal function, and lack of bladder contracture. So if somebody at the stage 1 stops using ketamine, and with bladder training and some medications to help relieve pain, and support from a specialist service like Inspire, that damage, they can stop it in its tracks and hopefully repair the damage that's been done. At stage 1, we would urge people to refer to us as a specialist service to provide that support and psychosocial interventions, but also be urging people to access support through the GP. Anybody at stage 2, this is where structural changes to the bladder occur. So fibrosis, which is scarring, and a thickened bladder wall, which will result in reduced capacity of urine in that bladder. So people will be unable to hold that. Occasionally, the ureters are involved. Renal function is still preserved, so it's not affecting kidneys and those other organs. And that stage, there'll be some benefit from bladder installations and intradetrusor botulinum toxin A injections. Got that out. So that's stage 2, and at stage 2, we would want people to refer to Inspire again for specialist support, see the GP, and then look at that referral onto urology. And stage 3, we still support people at any stage, and that's when things are really going downhill for that person physically. So they're in established fibrosis and bladder contracture, ureteric wall inflammation, hydronephrosis, and decompensated renal function. These patients are often managed with augmentation cystoplasty or urinary diversion, or with or without cystectomy. Sorry to get all those words out there. So that stage is where we're seeing people with really serious bladder damage that may end up being irreversible, where we're seeing young people at the age of 21 or even younger having the bladders removed and replaced with bags permanently. So we'll just skip on to the last. I'll go through this damage and pain cycle. This just shows once that the person is using ketamine, it's damaging the bladder, sometimes without them really realising, because they're taking a very powerful pain relief medication, and as soon as somebody stops trying to take that medication, illicitly, they're going to feel that pain, and then they get trapped in this cycle of kind of damage and pain. So, the physical symptoms become unmanageable. And if somebody's using that drug to numb the pain, they find it very difficult to get out of that cycle. So I'll just pop to the last slide, which is harm reduction. So these are the things that we would be advising people to come for support to our service. So beware of adulterated substances and carry naloxone. So although we're aware that naloxone does not work on ketamine use solely, we are seeing a huge amount of adulterated substances in circulation amongst our service users. So we do training, we deliver training, we hand out kits for naloxone. So if you're interested and you want some naloxone training, please get in touch with us. We say crush powder as finely as possible and alternate nostrils if you can, to try and prevent that damage escalating. Use test doses before taking a full dose. Try not to mix with other substances, particularly depressants and alcohol especially, as that exacerbates the damage that alcohol does to, the body physically. Don't drive while under the influence, of course. Take frequent breaks to avoid tolerance increasing and allow the body time to recover. Stay hydrated and stop using if the bladder issues occur. Seek medical attention as soon as possible in the beginning stages. So we're seeing people presenting to service when the physical damage becomes unmanageable for somebody, rather than at the beginning when they're struggling to control that addiction. Use in safe environments and with sober sitters because of the risk of dissociation. Practice safe sex as always, and refer to specialist services if somebody consents and they need some support with the drug use. So I think that is the last slide that I've popped on there. There is a QR code here on the slides. This takes you to our Eventbrite page about our training packages. I know that's just been a quick 10-minute whistle stop tour, but I'll pop some links in the chat as well. And if people want to get in touch with our team, then they can.
That's great. Thanks very much, Vicky.
Thank you.
So we'll now move on to the lovely Faye.
Thanks so much, Vicky. Thank you. Hi, everybody. My name's Faye. I am the cluster lead nurse for Central Lancashire, but I have a lead focus in physical health across the whole of Lancashire. My background is emergency and primary health care, and for the purpose of this presentation, we're solely focusing on North and Central Lancashire, as it was completed prior to our transition over to Lancashire. So the stats that I'll show you at the end, they are just for North and Central. Next slide, please. So I'm going to be speaking to you about Buvidal today. When I talk about Buvidal, I'm talking about long-acting injectable buprenorphine. We're going to be looking at how we implemented it into Change, Grow, Live, the challenges we faced. We've got some service user feedback and some case studies. And then, of course, we've got some data and some development priorities that I'd like to share with you. Thank you. So as a service, we started with having Buvidal as a treatment option in March 2022. Our approach was very nurse-led, so I led on the implementation with my colleague Sammy Watson, and very, very new treatment offer, so it took some preparing, but it was nurse-led. We looked at implementing clinic days, we had a lot of training, we built relationships with our pharmacists and our chemists. And then we had to be really proactive in engaging our clients, because with anything new on the streets, you know, people are very apprehensive. Next slide, please. So yeah, like I mentioned, we piloted it in March 2022, originally with very low numbers. As I mentioned, we had a lot of apprehension around long-acting buprenorphine. So we focused it on our rough sleeper cohort, our most vulnerable cohort, and we looked at it from a risk management perspective. That was also the type of cohort that were very open to trying any new medications that were going to help them. Very, very quickly, word of mouth spread, and we then increased it into our core offer. So not only our rough sleepers, but open to anybody who was interested in starting the Buvidal. We now have a waiting list, which is we would love not to have a waiting list as well. So some of the challenges we had and the responses, for example, we found that a lot of the clients were engaging with the nursing team when they were coming in to have their injection, but they weren't attending their recovery worker appointments. So we looked at creating Buvidal specific champions, so recovery workers who focused on a Buvidal only caseload. We standardised our psychosocial intervention offer, and we implemented a Buvidal workshop, and that was external to the service. So we found a lot of people that were commencing on Buvidal were looking at moving on with their lives, getting jobs, and they weren't wanting to come into treatment into the bases. So we then looked at a workshop external from our base. That is only in Preston, but we're looking at spreading it across Lancashire. When we initially started with Buvidal, we had clinic days on a Monday because we thought we'll start the week fresh. Very, very quickly, we realised that we have a lot of bank holiday Mondays, so that was impacting the clinic time. So we moved it on to Tuesday. In addition to that, it was great to have catch up with the service user on the Monday to prepare them for transitioning onto a long-acting injection and calm some anxieties. So yeah, we now have clinics every Tuesday. We did have some issues with pharmacies. It was a new medication. We have staff picking it up rather than service users. So we focused on really developing those relationships with the pharmacy. A lot of clients who would normally pick up the OST from other pharmacies were having to move for the Buvidal to be at set pharmacies, but great partnership working now. So it's really, really good. One thing we did notice was a lot of service users were getting really stable on their OST, but we found that other substances were increasing. Quite often it would be crack cocaine or alcohol, so we had to really keep an oversight of that. Next slide, please. So capacity, we found as we were increasing our Buvidal offer, because it's clinic led by our nurses, we looked at the capacity with the nurses. So it's now a whole team approach with the pathway. We noticed there was a lack of communication between the professionals involved. So obviously we've got pharmacies, we've got NMPs that are prescribing, doctors, nurses, and the recovery workers. So with anything, we implemented a Buvidal specific MDT that continues now. We had a lot of service users on low dose Esprinor. And Buvidal do not have an equivalent monthly dose. So those that are on 2 or 4 milligrams of Esprinor, there wasn't that equivalent monthly dose to offer them. And lots of service users that have been in on low dose, trying to taper off, trying to detox, that were really struggling. And we looked and we said, what can we do for this cohort of users? So we looked at increasing their Esprinor dose, which sounds counterproductive, but what we knew at this point was how successful Buvidal was at supporting people with their opiate detox in the community. So very carefully, we slightly increased their Esprinor dose, which was then gave us the ability to switch over onto the monthly Buvidal, and then those clients went on to successfully discharge from the service, which has been incredible. We have a lot of prison releases, so Buvidal is really big in the prisons now. It's first line treatment in most major prisons, so we were getting an increase of prison releases on Buvidal, and obviously it was our mission to continue that care in the community. So we did provide additional training for the criminal justice team, and we had to cap our core offer, which is why we have our waiting list to manage both cohorts of clients. So yeah, we've got some service user feedback. So I'll read these out. So this was a long-term drug user who was also street sex working and living in temporary accommodation. This lady started on a Buvidal in 2023, and by her own admission has started to take care of herself. She's having her nails done. She's very proud of herself, and she says no to all heroin that has been offered. She now has the motivation to be independent and reduce off her crack cocaine, and is no longer street sex working. She says, thanks to Buvidal, I can see clearly and I no longer want that life. This client had been in service for 5 years, on and off script, living chaotically, and she's just doing incredible now. Thank you. Another one there, Buvidal is a miracle drug. We do hear that a lot. It's the first time in 10 years that I am not using illicit drugs. I've just started a course in security to help with my employment, thanks to the employment team. This client had been in service for 3 years, started on Buvidal last year, and is currently on Buvidal still, doing really, really well in the community. And I wanted to pop this one in here. So this is a parent's journey. So this lady was a 38-year-old lady, a mother of 3 children, 2 under the age of 18. She was prescribed a hydrocodone when she was admitted to hospital in 2017 for gallstones. It was continued by her GP for management of pain, and it hadn't been reviewed for 8 years, so she would continue to be prescribed. In which point she then became dependent on her prescribed hydrocodone, and then started to buy extra from her dad's dealer. When she was referred to Inspire, she was taking more than 20 tablets daily of hydrocodone, some illicit, some prescribed. We commenced this lady on Buvidal in April this year. She did have initial worries because of the habitual behaviour of taking the medication. That's one big thing we've had to look at, is the behaviour change alongside all the psychosocial. But she did start it, and we got this testimonial after she had a second monthly dose of Buvidal, and she claimed that it has positively changed her life. She's regularly highlighting how she's become much better in person, but also more present to her children, which has just been incredible. She says she's lucky to have been allowed the opportunity to commence on Buvidal, as she had lost all hope with the dihydrocodeine. And she said it's not only saved my life, but my relationship with her children too. Thank you. So looking at our outcomes then, since we introduced Buvidal as a treatment option in March 2022, we have commenced 272 clients on Buvidal. We've administered 2,234 injections, and currently, and this is just the North and Central, it's now expanded, it's over 100, but we had 88 clients being maintained on Buvidal. The greatest achievement we've had here is the fact that we've seen a huge increase in our community opiate detoxification. So service users who had been stuck on low-dose Espranor or low-dose Viceptone, really struggling to just come off that final few mils, they are now detoxed because of Buvidal, which has been fantastic. So looking at our developments then over the next 12 months, we are committed to continuously improving our offer. So we want to look at increasing our numbers within service to be able to provide it to all service users that want it as a treatment option, so we don't have to have a waiting list. We do have a particular focus on our shared care development and pharmacy integration to further enhance access and continuity of care. So as I mentioned earlier, quite often those service users that are moving on to Buvidal are wanting to steer clear of services. So we're looking at shared care and pharmacies as being an option to deliver and administer Buvidal. We are looking to expand our Buvidal workshop to a weekly workshop rather than a fortnightly workshop. And obviously, as always, we continue to review our processes and our psychosocial offer. Thank you very much.
Thank you, Faye. Thank you for that. So we'll move on. We'll stop sharing now and hand over to Dami. You can take control and do your walkthroughs and things. Oh, I don't know if we've lost him. Whilst we've just got a couple of seconds, hopefully waiting for Dami to jump back on. If anybody in the call has any questions or anything, whilst we've got a couple of minutes, more than happy to direct to the presenters that have been already. Vicky's put some really helpful links and things in the chat there as well, so please do save those and share with your teams. We'll make sure we share them and as comms and things as well when we send out the recording. Really helpful. Got a question coming in. So question there for you, Faye, very area specific. I think we'll get a few of those actually from contractors interested in sort of where your service is covering.
Yeah, so we do cover Burnley. As I mentioned earlier, I've worked predominantly with North and Central Lancashire. We've since amalgamated across as one, so we do have a service in Burnley that will be offering Buvidal, yes.
And as that offer comes out in sort of different areas there, Faye, is there sort of, I know you've mentioned that MDT approach, is there sort of like lead clinicians and things that contractors can get into contact with, you know, rather than putting in referrals for person specific, if they want to be ahead of the game and know what's coming, is there a way of them doing that?
Can you elaborate on as in like a referral for Buvidal only?
Yeah,
Or
so rather than waiting for, a patient comes in and is asking, can I have Buvidal here? Is there sort of like a platform that contractors can access, or key contacts for separate areas that they can get in touch with if they're wanting the training in advance, or just to know where they stand sort of with supply?
yeah, absolutely. So for the Northwest, I'll pop his details in the chat, but John Horton is the lead for all of the Northwest. So any Buvidal inquiries could be made to him. If it's anything in-service specific, in the first instance, I would reach out to one of the cluster lead nurses for Lancashire, and we can support with those as well. And I'll pop our
Perfect.
details in the chat.
Lovely, lovely. Thank you for that. We've got Dami coming back in now.
Sorry, apologies to everyone. I was just trying to share my screen and it just went off, so I don't know what happened.
Have
If
another
I can
go,
just share
see
my
if
screen now.
Yeah.
Can you all see my screen, please?
We can't, no, we can only see you. Oh, there we go. It's come up now. It's come up now.
Yeah. Sorry, once again, apologies for the breakout. Just to give my background, my name is Dami. I'm the finance and contract lead for CGL. And today, I will say thank you to Faye and Victoria for the beautiful presentation. I'll be able to learn one or two things there as well. So for the supervised consumption, we're just here to give a refresher of how everything works as well. Because we've noticed that we've been seeing a lot of duplicate claims coming from pharmacies. And I feel like this will be the best time to talk about it on how to make the actual claims. So first off, the service has moved from claim by prescription to a single monthly claim, which I used to tell the pharmacy is one claim per service user per month. In a particular month, you only have to claim for that particular service user in a month. So when the pharmacy wants to input their claims into the system, this is the interface they're going to see. And it starts with the provision date. And I think it gets more complicated here with pharmacy, with the people I've spoken to. So the provision date is the date you input your claim into the system. That is the provision date. So I've seen a lot of pharmacy where they input their claims. Let's say now we're in November now, so they're inputting the claim in December. So they feel like, oh, okay, because we're inputting the claim on the 3rd of December, they will put the provision date as 3rd of December. No, it shouldn't be that way. So the provision date is the date you inputting that claim into the system. So it should be the last date of the month you are inputting the claim. Let's say you want to input November claim now in December 3rd, for instance. So the provision date should be the 31st of November, not the 3rd of December. So when you do that, you move on. We move on to the client's name. You input the client's name into the system. When you put the client's name in the system, it asks you the medicine type. Is it methadone, buprenorphine, morphine, or whichever one you want to do? You input it. It takes you to the drug type. You pick the drug type. Then the month of dispensing should be that particular month that you are dispensing for that particular service user. That is what you need to pick. Now, so it asks you, is it supervised consumption or it is not supervised consumption? So if it's supervised consumption, you click yes. And if the client is not on supervised consumption, you click no. And this is where it gets tricky. Before, we do claim by prescription. So you can have 5 prescriptions, you can have 6 prescriptions. So you just enter into the system. Then when you do that, we don't have duplicates. But because now we pay for the dispensing fee, so if you enter by prescription, it automatically generates duplicates. Let's say we have Joe Blocks now. You have 3 prescriptions. You enter Joe Blocks the first time, second time, the third time. What you are telling the system is we should pay the Joe Blocks 3 times for the on-dispensing element. Before the introduction of call mats, we don't pay for dispensing. But with the introduction of call mats now, there is a dispensing element. So what we need here, number of supervision this month is how many supervised consumption did you provide for these particular service user in this month? So if it is 20 or 25 or whatever, just put it in there. So I feel this should probably be in the space of like maybe 3 prescriptions. So what we need here is how many supervised consumption, not the number of prescription that you have. So if you provide, let's say 20 worth of supervision for Joe Blocks, for instance, for that particular month, you just enter 20 here. So now moving on, you go to where all missed. Can you hear me? Hello?
We can still hear you, Dami.
Okay, all right. Just to be clear. Can you hear me, please?
Yep, we can still hear you.
I'm trying to see what I share. Sorry. Can you see my the thing I share? Sorry, I'm struggling to see something there.
So you were sharing, but it's gone off now. So I don't know if you want to try and reshare.
Can you see it now?
Yeah, we can see it now.
Yeah, so the number of supervised supervision this month, so it should be the number of the supervised consumption you've given to that particular service user in that month. So it could be 20, it could be 15, it could be 10, whatever it is. Now you get to a point where all missed those late collection reported, then you need to report your missed collection or missed doses. Please do, because we've seen a lot of pharmacy who are not reporting on missed collections. We need to report on missed collection because of the safety of the service user as well. So this is another place where it gets tricky. Exactly, this is where the duplicate claims used to come from. See, have you dispensed at least 10 days worth of medication for these service users? So I've seen a lot of pharmacy come to me and ask me this particular question where they ask that, what if a client or a service user is on, let's say, buprenorphine and is also on methadone? So if they enter those 2 service users into the system, would that not be a duplicate? Yes, you can enter those for these services too. Let's go back to this place. Let's say assuming Mickey Mouse is on methadone and is on buprenorphine. So when you're importing the claims on methadone, for instance, when you get to this point, you say methadone, you click on methadone, you go down. The month of dispensing, you click it. If it's July, if it's November, whatever month that month of dispensing, it asks you, is it supervised consumption? If it's supervised consumption, you click yes. Now, when it gets to this point where it asks you this question, have you dispensed at least 10 days worth of medication for this service user? For methadone, if you are inputting methadone first, when you click yes here, by the time you are inputting the second medication, which is it can be buprenorphine, make sure to click no here. By the time you do that, then we won't have much duplicate. But if you click yes the second time again, because the client is on 2 medication, is on methadone and is on buprenorphine, then you're clicking yes in this place, where it says, have you dispensed 10 days worth of medication? That is a duplicate claims, because we can only pay for this dispensing just to 1 service user per month. So this is where you always see me in your email every time telling you have loads of duplicate claims that you need to cancel. So if we get it right from the start, it's just the same way I do tell service user, it is 1 claim per service user per month. And this is for the supervised consumption as well. The one for the unsupervised is different. So we have the provision date, which is, it could be the date you are inputting the claim into the system. That is the provision date. The date you put that claim into the system. Then you put in the client name. You take the medication type, medicine type. It could be buprenorphine, it could be morphine, it could be anything. Month of dispensing, it could be any month. If it's the particular month that you are in, that is the month of dispensing. Then is it supervised? So this is the non-supervised element. The first one I showed you is the supervised element. So supervised consumption, yes or no. What you need to click here is no, since it's not supervised. And also, like I said before, we need to record all missed collections, please, for the safety of the service user. So when it gets to this place now, you see, have you dispensed at least 10 days worth of medication for this service user? If you have said yes, if you've not, please do say no. By the time you do that, we won't have duplicate claims. this is just like a glimpse of how the duplicate claims appear. So if you can see my screen here now, we have provision dates for this. This is like an example of how it works. Provision date on the 1st of October 2025. Pharmacy, CGL pharmacy, this is the patient leak ID. So what happened here is this client is unsupervised. Now they've entered into the system 3 times for this particular client, probably because they enter it with prescription. So they are not entering it per month. So now what this does is we have the initials A, B, C. This is 3 clients now. Now, if we go down here, let me scroll down. It says 10 days. Yes, yes, yes. That shows that they've clicked that 10 days worth of medication for this particular service user twice. And what this does is, this is a duplicate claims. So I will have to come to your email and tell you to cancel this and this, because we can only pay for these 10 days once. So these 10 days should be yes, no, no, even if you want to enter into the system for these particular service users. And that is how it works as well. And that is it. So if the only thing I do say that I feel like it should be something we need to hold is, it is 1 claim per month per service user. So it is not by prescription anymore. We've moved from the era of prescription. So whatever supervised consumption that you've provided for their particular services for that month, that is what we need to input into the system. And that is it. So I will entertain any question as well. And also, we're trying to promote naloxone in our pharmacy. So if it's something that you'll be interested in, please reach out to us and we will be able to onboard your pharmacy as well. And for the annual pharmacy review, we noticed that we have a lot of pharmacy who are not taking advantage of the annual pharmacy review. You get paid £30 for doing the annual pharmacy review, and which is like a lot of money that you're missing on. I know that a lot of pharmacy wants money, everyone wants money as well. So you're missing out on a lot of money if you're not doing the annual pharmacy review. For instance, I have some pharmacy that have more than 80 service users. Imagine you getting paid £30 for each service user. That's a whole lot of money you are missing out. So just create some time to be able to fill in those forms, and you get paid £30 every time. Thank you.
That's great. Thank you very much, Dami. We can also send out some comms about the pharmacy reviews and things as well, for those pharmacies that are potentially missing out. That was really helpful. I think hopefully, especially once we get some people watching the session back, hopefully we'll stop some of those duplications. And as Dami said, he won't be appearing in your inbox that's not quite as much. For anyone that is on the Teams chat still, does anybody have any questions for any of our presenters just before we finish? And we had a little few minutes before, didn't we, to ask some. If you want to ask them in the chat or pop your hands up. I think someone was going to have a go then.
Dami, you know the payment method that you just explained, is that in the Blackpool area?
Say that again, sorry.
The payment method that you just presented, is that live? Is that live in the Blackpool area?
For Blackpool area now, we are not live in Blackpool yet. It is in North, Central, and East for now. So when it's time for Blackpool, we'll let you know. But it will definitely be the same way it is now for Blackpool. I think we have few pharmacies in Blackpool, not like we have a full control of Blackpool at the moment. I can say probably 2 or 3 pharmacies in Blackpool. Yeah. Do you know the name of your? Okay, sorry.
Yeah, it's Talbot Road Pharmacy. So just wondering if it's something that's going to go live. Do you have a date, or would you be able to come do some training before if we were to go live with your payment method?
I will allow Katie to answer that. So.
Thanks, Dami. So my understanding is if you currently have individuals attending your practice as part of an SLA with us, that would be paid under the CORMAT SLA. Some people in the chat may not be aware, but we have recently, it's been publicly announced that Changegrow Live have been successful in being awarded the core contract for Blackpool Drug and Alcohol Service. So we will be delivering services for opiate replacement therapy as being one of them from April next year. It's only just been announced, so we're really early days of working out the detail of it, but as part of that we'll be embarking and really keen to engage with all of the stakeholders in Blackpool, especially, you know, the pharmacies there, to see what would be the best way to work together.
Perfect, yeah.
Okay. And just to add
Because our
to
pharmacy is quite a busy one with service users, you see, so this will be really important for us.
And just to add to what Katie has said, because I've seen a lot of pharmacy come to me and say, "Oh, we are making claims and we don't get paid for it." So currently in Blackpool, I think it's Delphi Medical that is in charge of the Blackpool. So most of the time when your claim goes to Blackpool, it doesn't come to CGL, except we have service users using that particular pharmacy. So I think it has to go to Delphi Medical, because I've seen loads of people come to me, we make claims on pharmacoms for supervised consumption, and it's not coming down, we're not getting paid for it. So when I check the list of pharmacies that we have in Lancashire, we don't see those names there. So those claims should go to Delphi Medical for now, pending the time, as Katie has said, pending the time we have the whole contract in Blackpool, then we'll be able to do the core mat. So what we have, what they have, I believe, probably is just supervised consumption, not the whole core mat package.
I think when the time comes, obviously when you start going live and things as well, we will be available for support and for communications to go out. So we can discuss that between ourselves as well and make sure that our contractors are fully supported. So don't feel like you'll get left out of the loop or anything. We will make sure that we're on top of that and you all feel prepared. Vipul, do you want to come in with a question?
I do. Dami, thanks for the explanation. I'm guilty as charged. Initially, when the claims went out, I used to do multiple claims. I did find that what does help, what I do now in my pharmacy is literally an Excel spreadsheet. So the names go down the column and then 1 to 3 to 1 across the top. So once the blue script is complete, I'll put ticks into like the old system where they've done. At the end of the month, when I submit the claim, I just count the number of days that I've done. So at least I then know there's no duplicate prescriptions. Because initially, when I used to keep the scripts, they used to stay out lying around for endlessly. So I just want to get rid of them. I think maybe looking, if it's a problem or issues for pharmacies, it may be worth doing a simple Excel spreadsheet, names down the left-hand side, 1 to 31, and just tick off the days, because I find that a lot easier.
Okay.
Sounds like a good process.
Thank you so much, Patel. Yeah, I'm trying to do that as well, and I'm trying to do something like a question and answer as well, and an Excel spreadsheet where it explains all the process. And thank you as well, because I know when we started Core Mat, it was a very, very difficult task, because you're changing from the way you worked before by claiming by prescription now to just a single monthly claim. So it's very, very tasking. And I remember I've had this conversation with loads of pharmacy. I've tried to talk to them about it on how to make those claims. I've had like a team's essential like this, but still some pharmacy still have those duplicate claims, which is, you find a way of making it work easier for you, and probably because of staffing and a lot of things, a lot of factors involved. I could remember that I did a training some time ago, and we have loads of people in that training. And I spent up to like 10 minutes explaining to a particular pharmacy, this is how it should be done, and this is how that particular pharmacy. So, and the next time when I saw their claim, they did the same thing. So I went back, I spent 10 minutes explaining this process to you. What happened? They told me the staff that I explained to just left last week. So they can't know how to explain to the new staff. So I understand the issue of staffing as well, and a lot of things. So I'm trying on the process of having an Excel sheet, as you said, and also attaching some files, explaining the whole thing, then have a place where I say question, frequency, hard question, and put all those things intact, I feel that will work. Thank you so much for the heads up, and thank you for the suggestion. I really appreciate it.
That's great. Right, we've got a couple more minutes if anyone's got any last minute burning questions. As I say, the chat will still be active if anything springs to mind in the next few hours. And do remember that we will be releasing the recording as well for people to watch back. Katie, I know you'd mentioned that you'd like some feedback for that, wouldn't you? So we'll share that with you as well.
Absolutely.
But it's been a really, really good session. Thank you so much for managing to squeeze all of your information in the tiny time slots that we've been able to give you. And I'm sure we'll definitely be providing more training in partnership again, because this has been really, really beneficial. Anything else from our presenters? Anything that you've sort of missed, or any last minute comments?
Can I just mention, so Change Grow Live nationally, we've just had receipt of our annual report for CORMAT. This is something we've implemented across 10 services nationally as a way of increasing our investment in pharmacy, community pharmacy, at a time when financial pressures have been quite acute. So I'd like to share that via yourself, Lindsay,
Yeah.
as part of this.
Yeah, of course, absolutely. Okay, well, if there's nothing else, we'll let everybody go and get the last 7 minutes of their lunchtime back. Thank you very much to our presenters. We do appreciate people taking the time to support our contractors. And thank you very much for everybody that's attended today. Look out for the newsletter and social media posts that will follow. And be sure to get in any of those last minute burning questions that we'll take back to the team. Somebody is typing. Oh. So yeah, we'll let you go. Thank you very much for your time, everybody.
Thank you.
Thank you. See you later.
Thank you.